Good morning and welcome. I think there will still be a few people coming in and getting breakfast, et cetera, but I thought we should go ahead and get started. I'm John Kellum. I'm the Chief Medical Officer of Spectral, and I'll be co-chairing this session with Debra Foster, who's also from Spectral. And we have quite a lot to talk about, and not as much time to talk about it as we might like, so we're going to move quickly. Basically, we're going to have a couple of presentations by, I would say, seasoned investigator clinicians in the trial that we're conducting. But the goal of this, really, as the title suggests, is to talk about what happens next. So we finish the trial, and this is the crowd that's going to be asking questions about how to adopt the therapy. And so we're going to try to address what adoption will look like. How that looks in the real world, so to speak. So we have a couple of presentations from investigators, and then we have then we have a panel discussion, basically, and this is the agenda, basically, here we go. Yeah. So this is the agenda for this morning, and for those of you who are staying on with us as our investigators, we'll be having. Sorry about that. We'll be having a workshop, and that'll be for those of you who are here. I believe we stay in this room. Is that right? Or do we go? We stay in this room. So, for those of you who are staying for the investigator meeting, it'll be in this room as well. So, all right. So with that, I'd like to invite our first speaker to come to the. You'd think I did this for a living. Here we go. I'd like to introduce our first. Speaker, Danielle Davison, who's from George Washington University, to talk about patient selection and real-world applications. So, Danielle.
Thank you. Good morning, everyone. So today, I hope to talk about identifying which patients may benefit from targeted endotoxin removal and some practicalities of this therapy, particularly with incorporating sepsis bundles. So we're going to start with a case. This was during the pandemic. We had a 23-year-old woman who had an elective termination of a 24-week pregnancy at an outside clinic. The following day, she went to and had a planned D&E at that outside clinic. She was reported there to be lethargic, having rigors and abdominal pain. Her vital signs you can see there, she was tachycardic and hypotensive. They proceeded with the D&E, and they noted foul-smelling amniotic fluid, and she was transferred to our emergency department. In our ED, she was found to be encephalopathic, hypotensive, tachycardic. The sepsis bundle was initiated immediately, and then she went to the operating room for source control and was found there to have a necrotic uterus, underwent a hysterectomy and bilateral thrombectomy. So she subsequently came to our ICU. She was found to have now multi-organ involvement, acute kidney injury, evidence of DIC that you can see there, and an elevated lactate. She receives all the ICU care. She's on pressors. She gets resuscitated, blood products. She started on CVVH. Abdominal compartment is ruled out. The ventilator's adjusted. She gets antibiotics and whatnot. She does get an echo that demonstrates some depressed EF with an EF of approximately 30 to 35%. GYN's called back to the bedside. They explore her. There's no bleeding source. There's no dead bowel identified. Subsequently, her amniotic fluid comes back with E. coli, but her blood cultures are negative. So that evening, of course, is the middle of the night, right? That evening, the intensivist says, okay, I think the key to this young woman's survival is, number one, to provide better perfusion and also potentially to remove endotoxin. We cannulate her onto VA ECMO, given her profound shock with some degree of sepsis as well as some cardiogenic involvement. And we approached the family about Tigris enrollment. They agree. She has an EAA level that's measured at 0.69. She's randomized to the intervention group. We already had a dialysis catheter in place, so we used that for the PMX hemoperfusion and then used our CVVH through our ECMO circuit. She receives 2-hour sessions, times 2, 24 hours apart. On hospital day 3, her pressures are weaned, her lactate clears, she's now following commands. Hospital day 6, she's decannulated, her abdomen is closed. She has a prolonged hospital stay. Nevertheless, she goes to rehab and now lives a functional life. So what is endotoxic shock? How do we recognize it? We know LPS or endotoxin is a major component of the cell wall in the bacteria, on gram-negative bacteria, and is recognized by toll-like receptors on immune cells. This triggers a very rapid and powerful immune response, cytokine release, complement activation, their subsequent direct effect on tissues and mitochondria, further activation of neutrophils, importantly, thrombosis, platelet activation, consumption, endothelial dysfunction. And then at the bedside, we see typically hemodynamic compromise, high levels of lactate, multi-organ failure, particularly tends to involve the liver and the kidney, and evidence of endothelial dysfunction and coagulopathy. It is important to note as we move beyond the trial to remember that endotoxemia does not necessarily mean gram-negative bacteremia. LPS we know is released in various shock states, including in burn injuries, for example, trauma after hepatic resection. We can see it after gram-positive infection, fungal infection, COVID infection, and it's likely due to gut translocation when barrier function is compromised in settings of hyperinflammation or hypoperfusion. We actually looked at this at our own institution when we measured EAA in 96 critically ill patients with COVID, and we found high EAA levels were present in 87% of those COVID patients, and yet only 3 of the 96 patients had actual evidence of gram-negative infection. And we also found that, of course, EAA does correlate with organ failure and length of stay. And now, while the host response to endotoxin does vary depending on a patient's genetics, their previous response, or physiologic reserve, it's important to note some patients have relatively controlled levels of inflammation in which sort of ICU resuscitative care would be enough. But the patient population that we're really looking at are those with dysregulated inflammation and multi-organ involvement. So what does this look like at the bedside and who we should consider for endotoxic removal? These patients look very similar to other dysregulated immune response syndromes, such as atypical HUS, HLH, and what a relative recently report of 4 phenotypes of sepsis described as the Delta phenotype of sepsis. Those patients tend to have liver and kidney involvement, coagulation abnormalities, and an elevated lactate. And these patients tend to have the highest mortality. A recent post-hoc analysis of 2 PMX trials actually demonstrated, again, patients with elevated INR and elevated lactate, again, are those the ones that benefited greatest from this endotoxin removal. And this makes sense because endotoxin is a known trigger of DIC and endothelial dysfunction, and therefore there's a lot of likely clinical overlap. And we know from previous trials that anti-endotoxin therapy is ineffective if organ involvement is limited. Again, this is why selection criteria is really paramount. So when we're looking and trying to figure out which patient to select and the severity of organ dysfunction, in the trial design, it's easy, right? Because we have strict criteria. Patient has to have a MODS greater than 9, a SOFA score greater than 11, they have to have vasopressors a certain amount and have organ dysfunction. But on the right, as we move beyond the trial and you're at the bedside, sort of what are those clinical clues to endotoxic septic shock in the real world? So these are 4 things that I would consider. Number 1, is the patient obviously in septic shock and on 2 pressors are significant pressors. 2, is there organ involvement, particularly looking like that Delta type as I described. 3, are the lab abnormalities consistent with this? And 4, perhaps a checks and balance system where you have maybe another intensivist or someone else that looks in and said, yes, I agree with this, looks like endotoxic septic shock. I think we should proceed with this treatment. So in addition to recognizing this clinical syndrome of endotoxic septic shock, a really important part of this puzzle in identifying the suitable patient for this therapy is measuring endotoxin. We know high concentrations of endotoxin in the blood correlate with mortality, and yet clinically predicting the amount of endotoxin that's available to remove is actually challenging. Some patients have a very exaggerated immunologic response, but actually have low EAA levels, and this has been documented in trials. Some patients on the opposite side have very unpredictably high levels of EAA, and that may overwhelm the PMX fibers and filter, and therefore the inability for the filter to remove. Turns out measuring endotoxin in the blood is really difficult. LPS binds to proteins and platelets. It becomes rapidly sequestered by HDL and complement, and therefore free endotoxin can be low even when the burden is high. LPS differs by weight, size, and strain depending on the type of bacteria. And unfortunately, other tests such as ELISA and LAL, for example, have been elusive or really difficult to measure in whole blood. So what is endotoxin activity assay? Briefly, it's a chemiluminescent assay, and it circumvents this problem of measuring endotoxin directly by measuring the ability of endotoxin to activate the immune system. It's been around for a while, FDA cleared a long time ago, and it is a point of care test. It takes 30 minutes to run, and I think this is important when disease and timing of management is of essence. You can see my coordinator over there, who's an absolute expert at this. Again, it takes 30 minutes to run, but about 10 to 15 minutes of actual operator time. So I see no reason in the future why a lab technician would not be able to learn and do this and sort of do this while doing some other studies at the same time. So briefly, how does it work? You take 1 to 3 milliliters of blood. It's mixed with a reagent that contains IgM that has an affinity for lipid A that's on the surface of LPS. This stimulates the host immune response in the presence of complement. There's a release of oxidative radicals. In the presence of lumiphore, this creates photons of light. And then the luminometer on the right there measures these photons of light, which are proportional to the number of immune complexes. And that's emitted as relative light units. These relative light units are then converted into endotoxin activity in a range of 0 to 1. Importantly, and John just referred to this yesterday, importantly is this dose response curve and the corresponding endotoxin levels. So this dose response curve is logarithmic. So if you look over here on the left where it's gray, EAA levels that are low and intermediate levels, this score corresponds to relatively low endotoxin concentration. And therefore, there may be limited amount for the PMX hemoperfusion to actually work on. Very importantly, all the way to the right, which is the maroon, these corresponds to EA levels greater than 0.9, and that can be levels greater than or much greater than 4,000 picograms per milliliter or greater than 10 to 20 micrograms of endotoxin concentration. This is an issue for 2 reasons. Number one, this may be beyond the ability of this assay to actually measure the amount of endotoxin concentration. And 2, it may also be beyond the upper limit of the detoxification capacity of 2 PMX cartridges at a duration of 1.5 to 2 hours. So this is why, again, we're measuring or including patients between 0.6 and 0.9. And this makes sense in the post hoc analysis of the Euphrates trial. We did see a survival benefit emerge after we excluded patients greater than 0.9, and why the inclusion criteria in the Tigris trial is between 0.6 and 0.9. So, importantly, as some of the practicalities of performing hemoperfusion and endotoxic elimination, some ideas for real-world application. So how do we incorporate sepsis bundles in the future and while we're using hemoperfusion? Okay, just a little historic background of sepsis management. In 2004, the first set of surviving sepsis campaigns were published. Although published independently, bundles also came out, and this was in an effort to help execute these guidelines at the bedside in order to prove mortality from sepsis. And they have been updated approximately every 4 years as new trials of sepsis come out and as methodology has changed. After the 2018 revisions, a 3-hour and 6-hour bundle was then combined into a 1-hour bundle containing 5 elements. And you can see those elements over there: measuring lactate, obtaining blood cultures, antibiotics, fluid resuscitation, and applying vasopressin when a patient is hypotensive. I think you would all agree that these are relatively nonspecific. They address early resuscitative and supportive interventions. And I think it really underscores the importance and need for targeted therapy. Nevertheless, they are definitely important. So how do we incorporate these bundles with our hemoperfusion therapy? So as we move beyond the trial, incorporating sepsis bundles and hemoperfusion in the management of endotoxic septic shock. So processes and algorithms that address emergent conditions in a multidisciplinary and urgent fashion are well known to hospital medicine. Stroke attacks, for example, code blues, rapid response, obstetric emergencies, difficult airway response, just to name a few. This is an example of our PE response team and our response. This, I think, really nicely sort of incorporates elements including recognition of a disease process, patient selection, triage, activation, multidisciplinary decision-making, and procedural intervention. And I think this algorithm sort of translates well into a potential sepsis and hemoperfusion algorithm. So I've sort of mocked this one up, similar to our PE response team. The green represents sort of sepsis recognition. The yellow in the middle represents endotoxic septic shock workup, and the blue represents endotoxic septic shock hemoperfusion activation. So starting with green, whether it's your QSOFA or your news score, however your institution recognizes sepsis, first is sepsis recognition, if that's in the emergency department or maybe on the wards. The 1-hour sepsis bundle is initiated immediately, right? Blood cultures are ordered, broad spectrum antibiotics are given, patients resuscitated with 30 cc's per kg of IV fluids, hemodynamic monitoring is is done with an A-line, central line if necessary, a lactate is ordered, and vasopressors are started if the patient remains hypotensive. In our institution, if a patient has an elevated lactate or a patient is hypotensive on pressors, that's an immediate phone call to the ICU fellow. The ICU fellow would then, now moving into the yellow, would then perform the endotoxic septic shock workup. What does that look like? Number one on the left is the organ involvement assessment. So those include obviously doing your volume assessment with POCUS, what is the pressor requirement, performing the labs that are necessary to look at the organ involvement, necessary imaging and source control evaluation, and calculating the number of organs involved. Number two on the right is your endotoxin assay. Now, the fellow would now notify the lab if the patient is at risk for endotoxic septic shock, meaning they're on 2 or more pressors and they have 2 or more organ involvement. We certainly wouldn't want to send an endotoxic assay for every patient in the hospital that has sepsis. That would overwhelm the lab. And number 3, of course, is notifying the ICU attending and presenting, these are the labs, this is the number of organs involved, and this was the EAA result. The ICU attending would then consider to perform endotoxic septic shock hemoperfusion activation. I've put the criteria that I might consider for activation over here on the left, and this will sound familiar. Hemodynamic instability, a patient on pressors, severe organ involvement, 2 or more, 3 lab abnormalities that are consistent with this, 4 an EAA between 0.6 and 0.9, and we can talk about those ranges in the future. 5, no other terminal illnesses, and 6, getting another intensivist to concur to say, yes, I think we should proceed. What does activation look like? Of course, informing the family and getting consent. Number 2, inserting your hemodialysis line if it's not already present and getting our nephrologist to consult. Number 3, ordering the heparin and the PMX cartridge. And number 4, importantly, is letting the nurse know, right? They're going to be priming the circuit. In our institution, it would be the nurse that's running the circuit and involving them. So future directions as we move beyond the trial. In sum, number 1, quick and accurate identification of endotoxic shock is a necessary component to changing outcomes of this very deadly syndrome. Recognition of organ dysfunction patterns and EAA levels are key to this recognition. And number 2, targeting endotoxic removal using extracorporeal PMX absorption and incorporating this therapy into sepsis management may greatly impact the lives of this subset of septic patients. Thank you. Good. Go down. Does this work? No.
Thanks a lot, Danielle Davison. That was a really wonderful talk and a lot of great fodder for future consideration for all the folks here in the room. It's now my pleasure to introduce Javier Neyra. Javier is from University of Alabama in Birmingham, and he's an associate professor of medicine with a specialist as a nephrologist. So thank you very much, Javier, for being here.
Good morning, everybody. Danielle called for a nephrotic consultation. Here it is.
Yeah, turn it this way.
Yeah.
Sounds good.
Okay. Okay, so in the next few minutes, I'm going to talk about how we do early sepsis identification and the bundle initiation, and how this can be incorporated into identifying patients can benefit from the polymyxin B therapy, and the new therapies of blood purification, including the PMX. So this is our clinical decision support tool that we use for early sepsis identification and bundle initiation. So this is focused on early recognition and application of the sepsis bundle. You can see your window here of importance is from patient presentation to any type of care, could be emergency room, could be directly to the ICU if it's a transfer, and then you have these first 6 hours where this algorithm will try to identify certain patterns in the laboratory measurements, in the initial diagnosis that will facilitate that the clinicians incorporate the sepsis bundle. So now if we use this example and to the subsequent 6 hours after the early sepsis bundle is where we can tailor treatments recognizing endotoxic shock, and in this case, therapies like polymyxin B can play a role, as you guys heard before. Now, the goal, of course, of this is to change behavior, so to help clinicians to recognize the patients early, and with this, you can see that the flag that you can generate from this clinical decision support tool is a patient with potential sepsis, where you can initially incorporate your bundle. You can start, once the bundle is started, you can start the monitoring if the bundle was completed. And then when the bundle is completed, that patient will no longer be flagged and will be moved. What we use, for example, we use certain parameters like respiratory rate, the systolic blood pressure, changes in mental status, the acute SOFA score, and if there is any concern for infection that has been detected to the EHR, either to administration of antibiotics or through sending blood cultures or any type of cultures. And of course, the physicians are notified, and this is a continuous process that occurs through the hospitalization at the hospital. Now, we can see that the ability to have this clinical decision support tools, you can customize to your population, right? So for example, a lot of the times the algorithms use respiratory rate more than 20. And when we tested this, we noticed that we were triggering a lot of alarms of early sepsis. So this was customized to 22 to try to adjust to an alarm that clinicians can find functional and can use really effectively. So this is what you can generate these days, right? You can, from your EHR, let's say on the left side, you can generate all this flow of data and then create some dashboards. These dashboards can identify and flag the patients, and it will help you in the recognition, and not only in the recognition, but in the institution of the right therapy for the right patient. Doing these things, if you evaluate, are these tools helpful? You can see on the left side, before the implementation of a dashboard of a DART system for early sepsis recognition, you have here your ratio of observers versus expected mortality. And here you can see how, after the use of this clinical decision support tool, this ratio decreased significantly. And that's important because it may play a role in patient outcomes. And that's why we can use it when we want to customize our treatment, let's say for blood purification. So for blood purification, what we can do is we can move that window of recognition to the subsequent 6 hours. And then it's here when we can still use the flow of the EHR data to identify these patterns that Danielle mentioned of the delta phenotype. And you heard about this a lot from these clinical trials, identify this clinical phenotype of worse outcomes where we suspect the endotoxin levels are going to be high. And in these patients, we can tailor treatment. So this, we can roll this clinical decision support tool, as you heard, to identify the patient and then facilitate the endotoxin assay measurement. And after that, finally identify a candidate for a polymyxin B treatment in this case, for example. So of course, as you heard, and in Tigris, there is a window of starting the treatment after the initiation of pressors. So this clinical decision support tool can also give you an idea of where you are in that window to maximize the efficiency of the treatment. And I think this is important, right? If we do it successfully for the first 6 hours of bundle sepsis institution after early identification, we certainly have a window that is very reasonable of 30 hours after that to try to start the treatment. So this is going to be how potentially in the future we can apply these clinical decision support tools to generate this flow of communication between the intensivist team and the nephrology team to institute the treatment. So when you recognize the patient that can benefit from polymyxin B, so you can say you have a phenotype of a patient that at the same time needs RRT, right, in the same time window. Or you have a patient that there is no other need for RRT. So these are the two very classic patients we encounter, right? And we, for example, in Tigris enroll half and half. 50% of the patients had other indication for extracorporeal support, in this case RRT, and so we need to coordinate treatment at that time. So polymyxin B, I'm not going to repeat this, but as you know, has an intrinsic endotoxic binding capacity, and this is a membrane that has enhanced hemoabsorption and can remove approximately 5 to 10 micrograms of endotoxin in a session that lasts around 2 hours of treatment. So what are key aspects that the nephrology team should consider to institute this treatment is, first, you need to have availability of devices and trained nurses, right? Because you need to set up a new filter that they are not used to do routinely. So you need to have an adequate catheter, right? This is important because you need to have the catheter ideally in the right internal jugular side And if not, you need to have a catheter with the right length and importantly, the right diameter to run the treatment. 12, 13 French is what we always recommend. Now, the priming of the system is very important. Typically, you will prime with 4 liters of saline, and you will use unfractionated heparin 5,000 units in the last half a liter of the priming process. Then what we do, and we recognize that, and I will show you some pressures on the treatment, these patients will elevate very rapidly their transmembrane pressure. So we recommend to bolus this patient with unfractionated heparin, 1,000 units, just one single time. As you remember, the half-life of heparin is around 3 hours, so this should be sufficient for the duration of the treatment. And of course, because it's just a treatment is going to last a couple of hours, there is no need to monitor the APTT. But be careful in patients at high risk of bleeding. For example, patients with thrombocytopenia less than 75,000, you should be careful with your bolus of heparin. Close monitoring of the pressures, particularly transmembrane pressure and effluent pressures are the pressures that are going to be maximally affected during the treatment. Target the treatment 1.5 to 2 hours in 2 consecutive days. And then, of course, if the patient has other indications for CRRT, you should resume the treatment promptly, especially if there are still solid volume needs that the patient has. Very important, the communication between the intensivist and nephrologist and all the team in the ICU to be sure that this treatment is instituted in a safe way. So a couple of tips if you have a patient that still requires renal replacement therapy in the same window. So if there is an immediate solute control need, let's say patient has life-threatening hyperkalemia and you're still in the window of the 30 hours, we recommend start your CRRT, try to stabilize that patient, right? And remember, the dose of CRRT can be dynamic. You can prescribe for a short period of time and a high dose, try to stabilize some immediate solute control goal. And that's why a clinical decision support tool can help you to see where we are on the window that still we have time to institute the blood purification, in this case with the polymyxin B cartridge. Now, the CRRT and the polymyxin B cartridge can be delivered also simultaneously, but it's through different circuits, right? And there have been cases in which you can run through the ECMO one of the filters, and then you can use the dialysis catheter to provide CRRT, right? Or you can do it opposite. But it's not recommended on the same circuit to run both, right? So that's why these are exceptional cases. You have some flexibility there with the access you have on the patient to run both treatments simultaneously. Also, importantly, as I said, resume CRRT promptly if the patient still has solid volume unmet needs. And this dose of CRRT, you need to catch up because while you prime the circuit and while you deliver the treatment and the nurse have the resume CRRT, it may be a total of 4 hours. Patients still have unmet solid needs. You can prescribe for the next 6-12 hours a higher dose of CRRT above the average that we prescribe, that is 25-30 for a period of time until you meet your goals. And of course, if you have a patient that does not require RRT, if we already put the catheter and the patient is still critically ill, we typically will keep the catheter a couple of extra days in case patient develop indications of RRT and we don't need to do another procedure. So there are some things to consider, right? And to finish, options, right? Why heparin will be a good choice in patients that we are treating with polymyxin B cartridge. So remember, for CRRT, you have different options of anticoagulation. You sometimes don't anticoagulate the circuit. Sometimes you will use citrate. And sometimes, of course, you can use other type of anticoagulation, including unfractionated heparin, low molecular weight heparin, and there are other new drugs that are being tested for regional anticoagulation. But the thing is, if you think about unfractionated heparin, it's a 530 kilodalton molecule. The half-life is about 90 minutes, but in patients with severe kidney failure, it can last to 3 hours. This unfractionated heparin is mostly have an activity against factor 2A. That's why you monitor with the APTT. And in this case, if we are going to use it specifically for a treatment with polymyxin B cartridge, so we are covering during the duration of the treatment with one single bolus. And the bolus we recommend 1,000 is because in our experience we observed with 1,000 unit bolus, we were able to keep the treatments with no interruptions related to clotting. And it's a relatively conservative dose because if you remember the protocols in CRRT, we typically will bolus those patients with 1,000 to 5,000 units at the beginning of the treatment. That is equivalent to 25 to 30 units per kilogram. Right? For Tigris, we typically will go on the safe side, just 1,000, and with that we have been efficient in maintaining those circuits live. Very important, heparin is administered pre-filtered, and in the case of CRRT, of course, you have a protocol where you have a continuous infusion, and that is typically running between 5-10 units per kilogram per hour, and then you do monitor your APTT, right? But in the case of you're running a short treatment with polymyxin B, so then in these cases, one single bolus should do it. Some advantages, remember, it's effective, it's widely available. You can simply monitor it. Let's say if the patient already has other risk factors, you need to be careful. They may have a prolonged half-life even with a single bolus of heparin. You can reverse it with protamine, it's inexpensive. And there are disadvantages, right? So the patients can have bleeding complications, and also, of course, they may develop HIT, for example, sometimes even with a single bolus. So finally, this slide, when we have evaluated hemoabsorption treatments, you can see patients respond very heterogeneously to a filter with enhanced hemoabsorption. So in the case of our experience in the Tigris trial, you can see we have observed that during treatment that is highlighted there in green, patient has a very significant elevation in the transmembrane pressure represented there in orange. You can go up to 400, above 400, and then your effluent pressure also significantly is very negative. So this is important because this pattern, which is very consistent, and I think Johann and Debra will like this because very consistently we see these pressures in this patient. That means that the selection of the patient population for starting on the study, it's very homogeneous in the case that this patient can potentially, we're binding a lot of endotoxin that is reflected with these changes in pressures that are very significant and very consistent in all the patient phenotypes. So I think this is very interesting because this is a way we can monitor treatment, and at one point, if we extend our inclusion criteria, evaluate the effect of a treatment response. With that, I'm going to finish and happy to answer questions.
Thank you very much, Javier. Our next speaker is Johann Chang, who's from Spectral. Johann probably, and I think this is no exaggeration, I think Johann probably has the most experience, at least in North America, with this therapy in his role at sites in the trial, in both. This is not my first rodeo. So Johann. Yeah.
Thank you. I think the best thing I could do by following up such robust presentations is to be brief. And so thankfully here I have one slide. So as you can see here, it's running practical applications of the PMX treatment. So I think if you recall from John's talk yesterday, there are some barriers that we face, and one of them is staffing issues with ICU and nephrology staff. What we have here is that we offer flexibility for clinicians to run on 2 different platforms. And as you can see here, CRRT and hemodialysis. And so with CRRT, you can see there in the photo, the ubiquitous Prisma platform. So whether it's a Prisma Flex or the Prismax, incorporating our filter, you see the points that are there on the slide. One thing to keep in mind is with the PMX filter, we need to incorporate the actual filter into the Prisma Flex set. And so we have to bypass the Prisma Flex filter, which is obviously fixed to the Prisma Flex set. Next is the hemodialysis platform, and we're able to use multiple machines. So specifically, from the Baxter Artis, the Biberon Dial Plus, Gamble Phoenix, Fresenius 2008, and the Outsick Tableau, we're able to incorporate our PMX filter, and you can see the points there covered. I think with all of these platforms, it's important to note that there are considerations to make when it comes to the filter or the PMX cartridge. It is unique in the sense that it is fluid filled. So it is filled with saline, and through the steam sterilization process, it does become acidic. And so with the pH of 2 to 3, we need to do a 4-liter rinse of saline to get it to a more manageable pH of 5 to 5.5. And so Also considering the fact that we're running at a pump speed of 100 ml per minute, the whole rinsing process itself will take 40 minutes, and then we do heparinization of the circuit itself, which is another 10 minutes. So really rinsing and heparinizing the circuit will take 50 minutes, and that's not including the setup of the machine. So altogether, it's about an hour for setup. And now the final point here, the PMX treatment itself will take 2 hours, and again, running at a blood pump speed of 100 ml per minute. And that's obviously keeping in mind that we want the slow blood pump speed to increase the contact time between the endotoxin in the circulating blood and the embedded polymyxin B antibiotic in the filter. At the end of the day, it's 2 treatments within 24 hours. And again, like it's been reiterated several times, we are aiming to remove 5 to 10 micrograms of endotoxin. And so the last thing I want to note is that we do have 2 sub-studies that are associated with the Tigers trial. One of them is running the SAMI platform. SAMI is a RRT machine. And again, it's in this case, actually, it has customized software. It has customized bloodlines to run the PMX. So the setup, it does still take about an hour, but it is seamless where we don't have to do, as you can see, all those points there in terms of MacGyvering the setup. And lastly, we are embarking on a sub-study with the Prismax machine. And again, it's going to have tailored software. It's going to have tailored bloodlines and set to run a seamless treatment with the PMX. Thank you.
Thanks a lot, Johann. And he's really been a champion for installing and training and ensuring that these treatments are run successfully. And he's really quite an asset for our team. And he's always available. And he loves to jump on a plane and go to any of his sites at any time and help out if necessary. He's also really great at managing his iPhone from wherever you are and putting it on FaceTime, et cetera. So thank you very much, Johann. I also want to now call up the speakers to come and take the stage so we can have a nice amount of time for some questions. But I also want to introduce 2 other people who have been very instrumental in the success so far of this trial. And they're both ICU nurses. They're also study coordinators. They run the machines. They are really super women, I guess I could say. And they're both from Colorado Springs. Cindy Ramberg, thank you very much. And Tara Bowman-Gray. And you may recognize Tara if you've watched the morning show video. She's represented there, as well as Dr. Davison. So I'm going to move aside, and I'm going to have a roaming microphone. Dr. Kellum is also in our midst with a roaming microphone. And sir, would you like to start with a question? If anybody has a question. If not,
everyone's always shy, so maybe I can ask Cindy and Tara questions because I think that a lot of people are probably wondering, okay, that you've had all this experience with the clinical trial, but now the intervention is available. And when you have an intervention that becomes available for a very select group of patients, there's a lot of explanation that's needed for the family, right? Because people are going to want this, but it's not going to help unless there's elevated endotoxin. And other people are going to be scared of this because it's going to sound like, a machine, et cetera. So you guys have as much experience, if not more, in talking to families. So help us understand a little bit about, what that's been like. In other words, what is your conversation with the family like? How does that look? And how do you expect it to look post-trial?
All right. You want me to go? So Dr. Rains is our PI. He's not here today, but my kind of approach to families when I talk to them is to say, we may have another option to offer you. This is your sepsis and this is what's going on. And then I go in to explain the Tigris trial. We also were part of Euphrates. So fortunately, we can kind of bring that experience to say, we did this previous study as well. really from our perspective, that was a blinded trial. So our PI didn't know when people got the real treatment, but we definitely saw a difference, right? Like those people in the ICU that you'd go, oh, they're never going to make it. And then we would do a treatment on them and they would be like their pressors cut in half by the next day. So we just believe in this so much because we saw such great stuff with the Euphrates trial. And so I can talk honestly about that. And of course, the internet's available. So they go, like always, I find that the families are hopping online, they're reading up on the study, and it's always, I feel like, such an easy conversation, honestly, because they're so desperate for their family, their loved one to survive, that they are willing to try anything to do it. Post IC, if we get to a point where we don't have to consent people, it's going to cut that workload by 75% for sure. Because that process is like at 8 hours, really, from you come in, you qualify them. For us, we have to consent before we can run an EAA even. So you meet with the family and then they want this family and then you wait for them. We all experience those consent delays for sure. But I think once we adopt the treatment and avoid that part, it will save a lot of time.
Absolutely, yeah.
I've got a question here. Sir?
Thanks. The trial specifies 2 days of treatment. Looking beyond the trial, could there be a role of remeasuring EAA after the second treatment, and if there's elevated levels to continue on?
That's a good question. It's very interesting, that question. The trial is measuring serial endotoxin levels daily, right? When we clinically have tried to say, for example, this patient we are predicting is going to have high levels, sometimes we are surprised. So our clinical recognition of the patient with high endotoxin level, just with clinical assessment only and our tools in the EHR, sometimes we cannot predict the levels. In terms of response, we have seen very heterogeneous response. Some patients, especially in day 3, you can see a significant drop in endotoxin levels. Sometimes in day 2, still you have very similar levels that are high with a small variation. So now it's an interesting question if at one point there will be a role for additional treatment, and perhaps if you ask me how I will do it, I perhaps will do it according to that response in endotoxin levels need to be reassessed, and based on that trajectory, you can identify a group that perhaps can benefit from an additional treatment. But I think that will need to be tested, right?
I don't think it's published yet, but in Italy, the EUPHIS trial looked at some of that, right? So they looked at and I think you were involved in some of that, right? Where remeasured the EAA, and you had very few patients actually that were still alive that had EAA that was still elevated and could have got another column. Can you comment on what you were involved in that? This is Thiago Reis, who's now in Brazil, but originally or not originally. But when the EUPHIS trial was going on, he was in Italy and had experience with that. Probably has more experience than just about anybody in this room probably with this therapy.
I'm not so old to be in EUPHIS, but I have a clinical experience there in Vicenza with Professor Ronco, and it does not correlate. So patients may improve clinically speaking, but their endotoxin levels are sometimes they're still in the same when they were before the therapy. But
let me just paraphrase that, because I think people, I mean, it's a critical question, right? So we definitely know that patients whose endotoxin levels come down rapidly do best. If the endotoxin level remains elevated, they don't do as well as a group. But individual patients may still have very high endotoxin levels even after the second therapy. And I think there will be a pressure to say, if you've still got a lot of detectable endotoxin, but frankly, that might still be above 0.6. If you were 0.85 and you came down to 0.65 and you were still really doing poorly, I think there would be a lot of pressure for people to say, I want to continue. On the other hand, if the patient is doing quite well and the endotoxin levels have not really come down yet, remember it's not we say that, an endotoxin level, but the assay is a bioassay of endotoxin activity. And it really is how much the neutrophil senses endotoxin. And we don't really understand, as you unload endotoxin, how quickly that resets itself. So that's part of the issue.
And the assay is kind of a physiological biomarker. Of course, it's molecular, but you're measuring the activity of the neutrophils, which is really interesting. Can I ask a question? Okay, so this one is for Johann and Javier. Excellent talks, by the way. Concerning the technical part of running the treatment, when we perform hemoadsorption with the PrismaFlex platform, we think it's easier like to detach the part that goes to the warmer after the filter instead of detaching the inlet and outlet line because they are really tight attached to the filter. And in our case, so after we do this modification, we set the machine to SCUF, isolated ultrafiltration, with a net ultrafiltration of 0. So it means that the blood is just going out around the extracorporeal circuit. So why was the choice to do like Javier is doing there in Alabama?
Yeah, we do exactly that. So we don't use the blood warmer, and we will detach it, and we set the machine on ultrafiltration mode. So that's, and we use, as Johann said, blood flow typically around 100 mL per minute. We run it also with the PrismaFlex system. That's the device we have for CRRT. And again, so initially, in the initial treatments, we were only priming with heparin, and then we saw these very high TMP pressures and some alarms. When we start bolusing the patient with that extra 1,000 at the beginning of treatment, we start minimizing some of the alarms. So it's a key question that the machine set at SCUF mode, and you should avoid, especially if you are using it with Prismax. We have not used it with Prismax yet, but if you run a blood flow of 100 mL per minute, you are going to have some alarms with the warmer too. So I think that's going to be a key issue if you're thinking on using with Prismax. Johann, you want to add?
Yeah, I think going to your point in terms of accessing the filter or the set through the filter, we simply use a bit of grip strength, and we use mosquito clamps to detach the filter lines. So that's, yeah. A little bit, yes.
Thank you very much. I very much enjoyed these presentations, and I've learned a lot, in particular since the trial is not running in Europe, where I work. So I'm sorry to say that. But it was very educational for me. As I was listening to it, I understood it's fairly easy to run, and Javier made a very good comment and presentation. But my question really is, do you have to adjust the rest of the therapies? Do you have to adjust your antibiotics, your steroids, anything else when you apply this therapy?
No, everything else is standard of care. So, and that's when you're consenting the family, everything else is standard of care. Your antibiotics run, antibiotics are not removed by this filter. You continue your resuscitation, everything else that you would normally, you just now have a filter that's removing endotoxin. So the remainder of your care remains exactly the same. The only thing that might change, as Javier referred to, is if you are doing CVVH and a patient is acidemic or has a high solute load that you need to remove, you have to make a determination at the timing that you would stop the CVVH in order to run the PMX cartridge. And there's another case that I showed that we had to do that. So that's really the only, I would say, clinical change. Everything else would be running as usual standard of care.
So I'm Mignon McCulloch, a pediatric intensivist from Cape Town. So if Marlies is not using it in Europe, there's no way we're using it at the tip of Africa in Cape Town. But just a question, your experience in pediatrics, because we see a lot of sepsis and we lose a lot of kids from sepsis. And so I'm just interested to know if anybody's actually tried this in children.
We have not tried in children, and I don't know if it's a trial in the pipeline, but It's a good question.
Yes.
Yeah, I can address that. Thank you for the question. So this cartridge is manufactured in Japan. And in fact, in Japan, they do have a pediatric version and also a neonatal version. It's exactly the same cartridge, just made smaller in dimensions. So in terms of bringing it into North America, we have sort of two strategies on that. One is on the heels of Tigris, start up an observational study in pediatrics with the EAA, just to understand what the natural history of endotoxemia is in sick kids with sepsis, and then to follow that up with some sort of a clinical trial. It may be, the FDA does appreciate, I don't know if I could even say as strong as promote, pediatric versions of adult intervention. So we may have a nicer, fast-tracked kind of way to introduce to the peds population.
What's the weight limitation for the adult?
36 kilos. 36 kilos.
36 kilos. That's
Yeah.
an interesting number. Okay. So some kids would qualify. Larger kids, older kids would qualify, obviously, for the standard version. Let me ask you a question. Do you use plasma exchange?
We've got it available. We haven't started using it yet, but I'm looking.
Because there's a lot of pediatric centers around the world, including in the United States, where probably less blood purification for sepsis in general, but will use plasma exchange. And I don't know if there's anyone I can pick on. I don't see any of my pediatric colleagues in the audience, but a lot of them will. Well, Steve, you guys treat kids as well, and I don't know what your criteria is, but a lot of centers' criteria, phenotypically, is exactly this, right? And we're actually embarking on some studies now to measure endotoxin in that phenotype. And my suspicion is, although I can't prove it yet because we don't have the data, but my suspicion is the same ratio, about 2 to 1 of those patients will be endotoxin positive. So I suspect, and plasma exchange should work for endotoxin, by the way. The only problem with it is that you also pull out immunoglobulins and a bunch of other things you don't want to be taking away from a patient with sepsis if you had an alternative. So I suspect that it will replace plasma exchange in those patients who have demonstrable levels of endotoxin. Before I move to the next question, I just want to make a comment to Marlies that, you guys left the EU, and the rest of Europe, particularly Southern Europe, is using quite a lot of this. So maybe you'll come back into the fold in the future.
Yeah, I'd like to add that not everyone who comes from the UK voted to leave Europe, right? Yeah, just less than 1% decided the fate of the rest of us. But anyway, I've got congratulations, because having been involved in studies similar to this, I realise how difficult they are to run. Can you just tell me, for my own benefit, maybe it's just an English thing, but the patients never come in between 8 a.m. and 4 p.m., right? And so, we invariably lose patients in the study. What have you done to try and enhance out-of-hours recruitment, apart from get a load more staff, which is a bit expensive? And the other thing is that the first talk, and then when Javier was talking, you talked about the bacterial cultures. We rarely use cultures now because we use biofilm and bioarray assays. Do you use those to identify pathogens early on, and do you see an association with EAA? Because my argument with a microbiologist is I'm treating what you haven't grown yet, right? So, yeah. So it's 2 questions. Sorry about that.
Danielle,
Thanks.
Oh, sure. Regarding your first question, and you all might have.
And I didn't put it, full disclosure, I did not put him up to that first question.
And I think I have some slides later that I'm going to go through with this. With respect to, yes, I completely agree. It is always a weekend or a night that these patients tend to come in, or holiday. It's like when babies are born, right? They're only born in odd hours. We have a sort of a 2 system for consent for screening. We have our research coordinators that are looking through, and I'm going to show you that later as to how they look through the charts. But Well, we've educated all of our learners, our fellows, our residents about hemoperfusion and septic shock and what to recognize. So if you have a patient that comes in the night, first thing in the morning, we have a Tiger text system, which is a patient HIPAA compliance system, where they text our coordinator to say, patient 286 looks like septic shock, take a look, and then they do a deep dive into the chart so that we're not missing those night things. And the fellows have been educated about this and are very excited about it. So they're part of the research trial. And they also actually have been educated to run the treatments. So they're really involved in it. So that's how we sort of get through the night process. So it's a team effort, there's no question. Also, as the nurses as we enroll more patients, the nurses are now familiar. So the nurse might actually contact me and say, do you have that filter thing, that worked last time? And then they're contacting me as well. So it's really a team effort. As you do more, people are getting more and more familiar with it. Do you have it? Sure.
We have a smaller team at our facility. So really it's just Tara and I right now. We have the advantage though of being ICU nurses. So we are working in the units. She works night shift, I work day shift. So when she's on, she screens everybody. She'll text out potential, see what they look like in the morning, vice versa. If I leave and say, that one might get sicker, can you see what they look like through the night? And then when I get up in the morning, there's a message from her saying which way they went. We did meet with all the intensivists. So we have both medical intensivists and then we have surgical intensivists. So we met with all of them, education about what the study is. I just have my phone number plastered everywhere in their offices, in the bathroom, everywhere you can think of, just for people to be, hey, when you have this person who's vented on pressors, get a hold of me. So that's how we recruit, and we've really been successful that way. But for us, I think the key has been that we're submerged in the ICU and we're working with these patients every day. And as charge nurses as well, then we have that overview of every patient that's in the unit. And then also as a rapid response nurse, I've certainly gone and moved a patient to the ICU and said to my PA, like, this one's going to get sicker. This is going to be our research patient. So we're just involved right from the jump on them.
I just want to add to that I think in the future we have shown that the bundles for the early sepsis management can be implemented more successfully with clinical decision support tools. So I think that's the reason we can identify these patients now for the study, is because we are using that early recognition dashboard to identify the patient. So, and with the flags in a patient with suspected sepsis, the coordinators will kind of flag that patient. But when the already bundle is being applied, that means that clinicians already confirming this patient has sepsis, and they are starting the bundle components. And with that, with these are a patient that we really keep on the radar for that short window of time. So what I would say is, to apply a treatment like this, because require extra coordination, placing a catheter, and also calling nephrology, if nephrology is going to be the one running the treatment, and you still have a window of a few hours, but that could be in the middle of the night. But we have been successful in the nephrology service to provide 24/7 CRRT treatments, right? I think we can provide a polymyxin B treatment if we have the right pattern of recognition and early call. So I think that's what probably is going to be one way to implement this in the future. We'll just have a patient in a tailored therapy with a CDSS, and that will activate early call to nephrology to set up all this system. But yeah, so I think that's to us was very helpful that we already have a dashboard at UAB that helps.
And in real world and in the lab technicians, they are running until Saturday at 12 p.m. After that, there is no way to build an EAA. So we had to wait, which is not ideal. And other hospitals, they don't run a test, so the samples come to the main hospitals and the test is done over there.
Any other questions from the group?
Explain to the audience the purpose of the substudy. There's mention of two sub-studies using CRRT that
not been clearance for any kind of basic mode machines that are currently being used. And so what that means in terms of therapy that needs to be run on human perfusion, we are faced with this chicken and egg problem, which is to call it, if we have to go. Because if you have a Chemex cartridge that's run on human perfusion, prove that without any device to be able to run it, we see that will mean that there's no market for that, because there's no pump for that. So then people will have the pumps and say, well, why do we even engage in human perfusion if there's no cartridge? So thankfully, in this space, we've had great collaboration with the Davison company, for sure, who have an instrument capable of human perfusion. But in the meantime, Spectral kind of developed their own human perfusion machine called the Sand. So we started with a thought study at a couple of the sites with their Sand perfusion, providing other therapies, gone very well, and soon, and we even started already, if not very so it's been a really nice harmonization of our two efforts. Hopefully, we can all take
Excellent. That's a great way to end. And I want to acknowledge the excellent talks that and excellent discussion from all of our participants. So thank you very much. And thank you all for coming.